Welcome everyone. Thanks for joining. We are glad to have Dr. Sanjay Oak with us for today's Association for Socially Applicable Research talk. Thanks, Dr. Oak, for agreeing to do this. Just very short introduction. Dr. Oak is a pediatric surgeon who has been practicing in some of the apex Indian hospitals for over 2 decades now. He's also a medical educator and a prolific writer whose articles I enjoy in every Sunday's Lok Satta. But most recent credential of his is that he's the chairman of the state-appointed Maharashtra COVID-19 task force, and that's what we'll be talking about today. Sorry about that. All I'm doing today is I'm acting as a mediator between people who had asked those questions and Dr. Oak. So we'll jump into it right away. Atmika, Surbhi, let me know if my internet connection is not good, and you guys are co-hosts, so maybe if we have major issues, you can take over. Great.
Yep, sounds good.
Thanks. So, Dr. Oak, the first question that we had was, what's kind of the structure of the COVID-19 task force? And could you talk a little bit about roles and responsibilities in there?
Absolutely. Delighted to talk to all you young researchers. Pleasure talking to you. Task force was constituted by Honorable Chief Minister of the state. This happened on 11th of April last year. Initially, we picked up about 9 or 10 of the brightest of the lot who were available from public as well as private sector. Now, the doctors represent various faculties of medicine. There's someone who is a pulmonologist, there's someone who is an endocrinologist, there is someone who is having an infectious disease background, there's somebody having critical care background. So all of them represented different subspecialties, also catered to different age groups. And because we had public as well as private hospitals, all subsections and stratas of the society were represented. A very clear mandate was given. Now, imagine a situation last year in the month of April. We were completely groping in the dark. We didn't know much about the virus. We didn't know what are the medicines. And we didn't know what are going to be the likely projections and proportions of this disease. So we were told to reduce the mortality, reduce the number of deaths which are happening either in the ICU or in the hospitals. We were asked to suggest critical care ICU protocols of what drugs are to be given to different patients. And we were asked to suggest how we can augment and increase the bed capacity available in the state of Maharashtra. And the last mandate was if we could classify some hospitals for COVID and some for non-COVID. However, very soon we realized that almost all the hospitals are emerging into hybrid type of hospitals, which have to accept both that type of patients. So that classification then went for a toss. Now, the task force since then has met every Monday. We have finished about 68 to 69 meetings. All the meetings are extremely organized. There's an agenda drawn by Friday, circulated. The agenda refers to the relevant aspects as the disease is evolving. It poses problems and it seeks solutions. There were few additions, like somebody who was an ex-director on WHO from India, respected preventive medicine specialist and epidemiologist. He was inducted. There were few IS officers who were given the responsibility of executing the suggestions given by the task force. So the task force went on increasing in its size. And today we are about 12 of us who meet on every Monday. It's all virtual. We have never met in person since last April. The only time we met in person was when Honorary CM called us for a cup of tea. But all the business otherwise has been virtual. But there are advantages. We are literally in touch with each other 24 hours, 365 days. And every word that is getting printed in the world through the accepted scientific journals, and we usually refer to British Medical Journal, American Medical Journals, infectious disease journals, Lancet, BMJ, and Science. So every word that is being written about this disease is discussed. And then a distilled wisdom comes out as, okay, out of this, this is possible, this is advisable to state government. But if I may recapitulate, what have we done? Everything that we have witnessed in the state of Maharashtra since last April, and that included whether we should give hydroxychloroquine, yes or no, whether we should give some antibiotics like doxycycline to control and to prevent, whether we should admit tocilizumab, are there any substitutes available like itolizumab, the entry of remdesivir, the subsequent control of that, beginning of convalescent plasma movement, use of high flow nasal cannula in a big way to oxygenate patients admitted in the hospitals, use of pulse oximeter in the community in pockets like Dharavi, Mankurd, Govandi, and in multiple states of Maharashtra to pick up high-risk individuals, right up to vaccine, right up to the oxygen shortage, right up to giving the idea of running an oxygen rail and getting oxygen from different states, erecting field hospitals, and now a cause for home vaccination. Every suggestion that task force has done has proved to be valid. Are there any arguments? There are a lot, because when more intelligent people come together, there are bound to be. I mean, we agree to disagree. So we respect each other's differing opinions. And then my job is to come out with a distilled wisdom, which is executable. Because otherwise, if you just collect figures, then you will become merchant of statistics, but not mavericks of medicine, which is required. So you must eventually come out with things which are doable. And doable not only in Mumbai, Pune, Nagpur, Aurangabad, but equally doable at Parbhani, Hingoli, Jat, Kautimhankal, so many other district places. So the idea of task force was then subsequently multiplied at individual district levels. And then we started having communications with them. We have had a series of meetings with doctors in the state. Our personal mobile numbers have been flashed all across the state, and the entire 1.5 years, we have received calls directly from anybody in the state seeking advice for the patients. At times it used to be really irritating. But you suggest something, and on the second or third day, the person returns a call, says that, sir, you advised this thing and the patient is doing fine. And then you say that, yes, whatever you are doing is on the right track. We have had series of meetings with divisional commissioners, collectors, policymakers, ministers, national task force, think tanks everywhere, right up to ASHA workers and Sarpanch, who runs various villages. So I think the vertical as well as the horizontal penetration of concepts put up by task force across the state has been extremely commendable, and I'm happy to lead such an intellectual body. A task force is ultimately an intellectual advisory think tank. So I write the advisory every Tuesday morning, send it to the Department of Health and Department of Medical Education. They pick up the essential things which are executable, and that is circulated all across the state. This is how we function.
Yeah. Yeah. Thank you. So that was really an elaborate and very still precise answer. Thank you for that. Kind of in the same domain, the next question is that one of the most significant intervention that we saw coming up in this pandemic was lockdown. So what was kind of the thought process with respect to like Maharashtra's lockdowns, and what were the challenges then thinking about reopening the economy?
Yeah. I have always said that lockdown is a science and unlocking is an art. And we have to learn both these things and balance. No lockdown decision can come from medical people, because a lockdown has economic, religious, and social connotations also, which need to be considered in the entire social fabric of your state. However, there were some parameters which guided us. The first and foremost was the case index, prevalence of cases in a given pocket. The second was positivity ratio of the test which were being done. The third was case fatality ratio. How many of them are dying eventually? So on this basis, and then something else was added. One was adherence to COVID appropriate behavior by populace in that particular pocket. And now the last thing to come up is the amount of vaccination that has been done. So if in an idealistic situation, when the prevalence is dropping down, there is a downward trend, the case fatality ratio is very much less, it's less than 1.5 or 1. Total number of cases are dropping down to single digit numbers. People are masking and double masking themselves. COVID appropriate behavior has really sunk in them as hemoglobin. Well, and the vaccination has progressed to a substantial amount that if you do a sero survey of a given populace, you find at least 50 to 60% of the populace showing neutralizing antibodies to a satisfactory titer. This is an ideal situation when you can say, lift up the lockdowns, lift up the restrictions. But unfortunately, this doesn't seem to be happening. This is not the order of the day. There are conglomerations for political reasons, for elections, for campaigning, for marriages, for deaths, and for funerals. The mask goes for a toss. I always say that if in Mumbai, if I'm waiting in the car, waiting for the red signal to become green, in the last 10 seconds, if I count, I can easily count more than 10 people who are without masks, or whose mask is somewhere here and not covering the mouth or the nose, which means its practical purpose is defeated. So if you are not going to be compliant to the basic requirements of preventive aspect of COVID-19, you can't dream of Singapore model. On one side, you need vaccinations to go up, which again, I'm not greatly satisfied the way the vaccination programs have gone in. And I'm not at all satisfied with COVID appropriate behavior adherence. That in nutshell will explain you why there are restrictions still in book.
Yeah. Along that same line, I think like if the way at least we try to see it, compliance is kind of built into the trust between what the authorities are saying, what the governments are doing and how the people feel about those actions. So in general, the pandemic has been a test of trust for state forces across the globe. In that regard, how do you see a scope for improving that trust between authorities and public, and how should we navigate that?
Siddesh, I am an eternal optimist, so I would never give up. I'll explain you what happened. Let's go back a year ago to answer your question. If you compare India, and let me restrict myself to Maharashtra since I lead that task force, with the rest of the globe, in the first wave, we really did well. We really did well. I was wondering, and the projections that our Delhi colleagues had made, even from Mumbai, were running in lakhs. Were running in excess of 15,000 ventilators, and we were not even 1/7 of those projections. If you talk of number of test centers and the RT-PCR test, we had only 2, one in Mumbai, one in Pune. But then, whatever steps were taken, today we are in excess of 530 centers which do RT-PCR. The control of the first wave, the less number of lives that we lost, more so the lives that we lost had extensive comorbidities which could be attributed to those deaths, and relative protection of under 40s and children was something that was notable considering the less number of health infrastructure that we had in our state. So I think people responded well. People responded to the call given by Honorable Prime Minister and the Facebook Live that Honorable Chief Minister Sir used to do. I think as the lockdowns got extended, then the lockdowns slowly got converted into a concept of you being in a lockup. You were in financial lockups. A phone call from HR department of your office used to spend a fear, a chilling fear down your spine that, oh my God, have I lost my job? Significant number of grade earners either lost their job or there was a 30 to 40% reduction in the carry home packages that people were doing. Work from home was appreciated, but there would have been limits to what it could have been done. So, come to September, October, we were done very well. The figures were less. We were having beds available in the hospital. Oxygen scarcity was unheard of. And this continued till almost December. Now, this was a phase of complacency, and the task force was repeatedly indicating that the worst is yet to get over. And why we were saying that? Because we were reading of second lockdowns, beginning of third waves happening in England, and they were bad. They were worse than the first one. Similar experiences were shared by Italy, Norway, US, Brazil, even the countries which had claimed that COVID to have completely gone, like South Korea, were again seeing cases. Singapore had revisiting cases coming back, while China, we always doubted what is truth and what is being communicated to the world outside. So on this background, we were saying, please do not reduce the number of tests which are being done. The whole principle of this trust is on 3 T's: testing, tracking, treating. One infected or one positive person, if he goes around, he can infect and pass on this to 400 people. If he's careless, if he's callous, if he's complacent, And all these three C's happened, and that dented the trust. On the top of that, when the second wave started, the virus had become more intelligent. The virus was mutating. We were getting different variants. So look, this is a devil's combination that you can think of. On one side, you are not doing enough on the preventive aspect. You still don't have vaccine in your hand because the vaccine came on 16th of January. And on the other side, the virus is changing for worse. The virus is going on increasing its infectivity many, many more times. This led to the second wave, which came with a vengeance. And what happened? If you ask me, so what was the difference between first wave and second wave? In first wave, if there's a family of 6, one person used to get affected. In the second wave, all the 6 family members were getting affected. The age of affection had reduced by at least 10 years. And this time we were seeing 30 years, 40 years. This time we were seeing the infection spreading like a wildfire and people deteriorating with an astounding rapidity. That led to non-availability of beds. All those stories of ambulances lined up, persons not being able to be offloaded in the hospital, oxygen scarcity. Maharashtra was able to produce about 1,300 metric ton of oxygen. And in the peak of pandemic in the second wave, we were in need of 1,700 metric ton of oxygen. So there was a deficit, there was a gap of about 400 metric ton. So all these things led to a concept of whom to believe, what to trust, and that led to a dent of trust, which we took time to come back on the track.
Yeah, coming to like some of those problems, what changes would you like to see more sustainably, more long term, when it comes to our healthcare system as a whole, at least in Maharashtra?
Oh, a lot needs to change. I have always said that COVID has done enormous harm. COVID has taught us some good lessons. It is up to us now not to forget this and improvise the system for better. It's an opportunity. And in every calamity, I see for an opportunity. Let me enumerate. First important good thing, and you will agree with me, that happened was 75 years post-independence. First time, public sector and private sector came together. And they worked for a common societal good. This was the first achievement. All these years, we had rifts. Public sector people used to blame private people, sare paise kamate hain. And private sector people used to blame public sector people, sale sirf academic hai, kaam ke nahi hai. I think for the first time, that particular meeting of minds happened, and we need to carry this ahead. That's the first lesson. The second lesson that we learn is that we may do cardiac surgeries. I might operate, as I operate every day in the morning, a 1-day-old child, a complex procedure. But what's the good of these liver transplants, coronary bypasses, and robotic surgeries and my laparoscopies would be if I'm going to lose the same patient because of COVID or some other things. So the social health, the infectious diseases from here on will top the priorities of medical planning. How many infectious disease hospitals do we have in our state? I can't count it on the fingers of my one hand. How much of importance we are giving to the infectious disease as a syllabus when I was an MBBS student from 1977 to 82. We were given a 15 days posting in Naidu Hospital of Pune, which was then an infectious disease hospital, and Kasturba in Mumbai. It's need that we build now infectious disease hospitals in our main metropolitan cities, develop a kind of hub and spoke model around them to cater to the populace around, focus everything on cleanliness, vaccinations, immunizations, and nutrition, and then carry the clinical excellence that we want to do. The third thing is, somewhere your penalties for misbehaving in the society when it comes to public health need to be rationalized. When we are charging 200 rupees for mask, the world is charging in dollar currency 10,000 rupees plus. When we are charging 100 rupees per spitting in the roads, the world puts you behind the bar. And therefore, I think the fine, the penal actions that we do for spoiling our society, for spoiling our community, for spoiling our villages and cities need to be rationalized. There has to be a fear component in the mind so that the discipline is maintained. The next point is financial allocation. Now, you are research students, so you know how minuscule percentage of gross domestic product is actually spent on health. Some of our neighbors like Nepal, Sri Lanka, and few others around tend to spend more. Now, US spends in excess of 17% on health. Now, I don't want to say that, okay, from 2022, it should be 20%. It's not possible. But we must have a defined fractionated program that should go on in next 2 or 3 5-year plans that we will definitely increase the GDP spending on the health. We have to adopt technology. But in technology, everything that comes outside is not useful. I say sometimes we are presented with toys, but not the technology that will change the healthcare dispensing. But what is useful now is POC, point of care contact instruments. For example, when a patient becomes serious, when he is in ICU, we monitor the oxygen concentration in the arteries, in the veins. So we do what is called as arterial blood gases. It's a tedious procedure. You draw an arterial sample, send it to the lab analyzes, comes back. It takes time. And we need to take corrective measures depending on those reports, whether the patient is in acidosis or alkalosis. Not anymore. I have this size small handheld analyzer available. It's a point of care contact blood gas analyzer. I must use such technology. You all have seen X-rays. In the last few years, the X-rays have become digitalized. You all must have heard or seen in hospital what is called as portable X-ray units. It's a portable X-ray unit that can be loaded on a minivan, taken into the camps. It has got wheels and it can be wheeled to the bedside of the patient. Now there is something step beyond that. I have an ultra portable handheld camera-like X-ray unit available. It's just like I'm having an Olympus or a Canon camera in my hands. I shoot it, hold it against the chest and shoot it. I get an X-ray on the screen of my laptop. Such point of care technology must be adopted. You looked at and you heard of various diagnostic tests that evolved. For example, when RT-PCR started about 15 months back, the report used to come on the third day after 48 hours. Today, we get the report in about 5 or 6 hours. And we have an antigen test. We have a home diagnostic kit now available. This is progress. This needs to be adopted further when we plan. And my last point about answer to your question is that we have IAS, we have IRS, we have IFS, we have Indian Revenue Service. Why can't we have Indian Health Service, IHS? I want doctors after MBBS to do that course and plan. I can tell you from my own example that out of about 17 graduate and postgraduate qualifications and fellowships that I possess, significant number of qualifications are in health administration, general administration, human resource management, and law. And all these things have helped me in my last 16 years of health sector administration. But basically, I am a doctor. I know what the patients need. I know what are their demands. I know that they don't have money. I have to provide. So you need a confluence of medical knowledge, and it need not be MBBS. It can be BAMS, it can be BUMS, BHMS, any faculty, clubbed with administrative knowledge with that, and you come out with an Indian health service. I think it's high time that at the 75th year of our independence, we institute this. I stay.
Yeah, no, those are some excellent suggestions. Yeah, I think which a lot of people and stakeholders should take seriously. We'll also definitely put them out as part of our blogs and our social media as the 5 pointers that we need to do. Pushing towards a little bit forward and how we go from here, I think there are 3 kind of like areas that we would like to discuss. The first one is you have talked a little bit in past half an hour about vaccination. So in that regard, I have 2 related questions. One is what's kind of the goal for Maharashtra with respect to vaccination in the remaining year? Do you think we can achieve that goal? And is there an Indian vaccine hesitancy problem growing in this COVID pandemic?
Yes, there is an issue of vaccine hesitancy. Why has this vaccine hesitancy come up? I think partially, and I'll be honest, the administrative policies have been responsible for this. We have changed the dosages, we have changed the interval when the second dose, particularly in case of Covishield, and people start believing. Initially, we said 28 days, then we said 3 months, then we said 82 days. So people somehow get an idea and a feeling that, oh, you are wavering because probably you're not having stocks. Yes, that could be a partial truth. But the real scientific truth of this wavering interval is the titer of neutralizing antibodies that a person develops after the first dose. And you need to give the second shot, a booster shot, when you are at the peak of those neutralizing antibody titers. So as it stands just now, it's 82 days as far as Covishield is concerned. As far as Covaxin is concerned, it is 28 days and it hasn't changed. No third vaccine is yet available. Sputnik is on the horizon, but there are some factual problems with Sputnik preservation. You need minus 18 degrees centigrade, and you need 2 to 8 degrees centigrade storage facilities. Sputnik is a vaccine that is to be given in 2 dosages. And there is a difference in Sputnik as compared to the rest of the vaccines is that the first shot and the second shot are different in terms of a vector. I'll explain. What is a vector? A vector is a vehicle. A vector is a vehicle that carries COVID virus inside so that the immune system can fight against that. In the first shot, it uses an influenza-like virus. In the second shot, it uses an adenovirus. It's a type of virus. So the vaccination is complete when you receive both. About Johnson & Johnson, it is supposed to be a one-shot vaccine, but we have no access to that as it stands today. About Pfizer and Moderna, they are expensive, and Pfizer requires -70 degrees of storage. Now imagine we may still do that in Mumbai, Pune. As I had said, let us create hangars on the airport so that the vaccine as it lands, we will line up at the airport and get it. But can I do it for the interiors of Maharashtra? Can I do it for my village folks? What about the cold chain maintenance during the transport? So there are logistics issues when it comes to these two vaccines. So if you consider the availability of the vaccine is happening in batches. That's why you hear 4 दिन vaccine है ही नहीं. अब मिल गया, 1000 मिल गए, खत्म हो गए. So that kind of reduced amounts which are coming in is eventually delaying the vaccination of the state and also of the country. If something doesn't drastically change, which we all hope and expect will happen in the month of July, because we are going to receive a handsome quota, with the prevailing pace, it may take 2022. And I don't want that. The earlier at least 70-80% of your populace gets vaccinated, there are better chances that the community will develop herd immunity. And once a herd immunity comes in, then there are less chances that fatal COVID will take place. See, I've coined my words carefully. If you take vaccine, doesn't mean that you are not going to get COVID. You may still get COVID. But at least you will not land up into ICU, and it is unlikely that you will die. So it's going to give you a protection. But as I said it is the amount that is being made available that has led us into a whirlpool of interrupted distribution of vaccines, of interrupted vaccinations happening at centers, and that has led to vaccine hesitancy. Plus stray reports that, oh, someone developed COVID after vaccination, or oh, someone died after vaccination. These instances are far and few. When you consider millions being vaccinated, these instances do happen. There is no medicine which is safe. There is no drug which hasn't got a side effect. But the benefits that one accrues because of such mass vaccination programs far outweigh the risks associated. And therefore, we need to adhere to it.
Yeah. For the coming months, I think there is a lot of chatter also about the third wave for India, for Maharashtra. So, having served in task force, how do you see to like potential planning for that, and how much of it is currently a myth versus something that we should be really concerned about?
I pray God and I expect that proves to be a myth. But I'm not going to accept it as a misconception. It's my nature that I prepare for the worst. It's perhaps my built-in nature because I am a surgeon. So if I know that the patient is going to bleed when I'm taking out a tumor, I would perhaps be ready with 2 or 3 units of blood before I make the incision. So therefore, looking at the scenario that the world has undergone, I mean, there are countries where there are 4th and 5th waves now in progress. It would be unwise to say that, oh, we will not be hit by 3rd wave. Several universities, several scholars have used various mathematical formulas, and that includes universities like even Harvard, Wisconsin, to some of our northern state universities, and I must quote here Professor Vidyasagar, who has used a model called as Sutra model, S-U-T-R-A. It's an acronym. And then there are various projections. Now, these projections almost agree on a fact that the 3rd wave will happen. What they differ is about the timing, is about its tenacity, and is about the tender age that might get affected. So there are people who have said that, don't worry, probably the 3rd wave is going to hit us somewhere around November, December. There are people who have said, no, that's a bit too far-stretched concept. We should expect it and be prepared for September. Whereas there are people who have said that, oh, it might happen in next 2 or 3 weeks. Why has this been said? Is the 2nd wave truly over? The answer is no. In fact, in our state, we have coined a term, the task force has coined a term, and we say that 2nd wave has a thick, long tail. It has a thick, long tail. It is not vanishing. It's not disintegrating very quickly. In fact, at some places, when we see the number of cases going down, before it touches the x-axis on 0, there is an again upsurge that is happening. If I tell you today, almost all the hospitals have started seeing again increase in the number of cases. All our ICU beds have become full. This was not the situation last week. Last week, we used to say, ICU beds are occupied, but there are vacancies in our general ward. This is slowly changing. What does it indicate? It is indicating that our efforts are yet suboptimal. They are inadequate. We must make more efforts in terms of education, compliance, COVID-appropriate behavior, and post-vaccination as much as possible. And still continue the restraints, the reins that are holding back.
Yeah. You talked a little bit about like the fear about the 3rd wave hitting the pediatric group children. So hopefully that won't happen. But if that happens, what's kind of our contingency plan with respect to prevention, but also clinical care?
Yeah. So apart from the fact that I am a pediatric surgeon who heads the task force, there is a separate task force constituted. And Honorable Chief Minister constituted that with the best of pediatricians that we have in the state. We all sat together. They created independent documents and they came to discuss with us in our meetings. And we have laid down very solid 10 or 11 documents. First is symptoms as to how the children are likely to present. What are the symptoms with which the children will come to you? In cases of children, there is something serious called as multisystem inflammatory syndrome. It is called as MISC, C for children. We have already seen some of the cases of this MISC. So we narrated symptoms. We classified the cases in a second document, that which one can be managed in the home, which one needs to be admitted, which one needs to be given oxygen, which one needs to go into a high density unit, and which one needs to go into ICU. That is second document. There's a beautiful document that the pediatric task force created about ambulances. How the pediatric ambulance should be, what it should be equipped with, and how a transfer of a baby should happen from his home to hospital or from a district hospital to a specialized children's unit. We also created documents about probable medicines, because as you know, the vaccines are not yet being given to kids. What we have started now are experimental basis vaccinations of children. We have also looked at age groups. See, when you say pediatric, it's usually up to 12 years in our country. And when you say adult, it is usually beyond 18. But then this lot of 12 to 18 becomes very strange. Na idhar ke, na udhar ke. So this time we say that when we say pediatric, we even take care of this adolescent group of 12 to 18. And that's why you must have seen and heard that the vaccination started first in 12 and 18 on an experimental basis. We saw that it is safe. Now we are narrowing it down to about 3 years to 10 years. We also indicated what are the various drugs that can be safely used. For example, you can't use remdesivir. You can't use tocilizumab. You can use steroids. So in what dosages you can use? Can you use antiviral drugs? Can you use monoclonal antibodies? Can you give the child a convalescent plasma? And can you give what is called as IVIG, and in what dosages? All those things we have listed. Then we looked at the number of beds that are available, and we felt that it's not adequate. The number of beds are not adequate. The number of oxygenated beds is less, and the number of ICU beds and dedicated ICUs are far and few. So we made a concentrated effort in the last 3 weeks of augmenting the already existing beds, adding more number of ICU beds, creating field hospitals, and creating sections of mother and child, because child cannot remain alone. So mother and child in field hospitals. We also said that vaccinations in children, not COVID, but other vaccinations must be completed. Because in the last entire year, in some places, some vaccinations had gone for a toss. So we said and insisted that they must receive vaccines. This is all the preparation that has been done, and a very tight, close monitoring is being done on the children.
Yeah. No, thank you. That definitely sounds promising. One more area that I think that a lot of people are scared about, concerned about, is a new phenomenon, or like the new vocabulary for it, called long COVID. So we are starting to see case reports that COVID patient didn't have diabetes, now have like diabetes, type 2 diabetes, neurological problems, aphasia, stroke. So how is our medical education, but also clinical management, gearing up towards that, given that we have had such a huge caseload in India now? So maybe there are a lot more people in India who will come up with these problems.
Absolutely. You are spot on. These are called as long COVIDs or long overalls. Now, I have myself been a victim. I was pretty badly affected exactly a year ago. I was in ICU on these days, and I went right up to ventilators. I came home, and it took me almost about 4 months afterwards to come to near normal. And even today, 1 year down, if I want to run to catch a local or ascend a staircase at Dadar or somewhere else, I need to pause. So there is virtually post-COVID becoming a reality. And as you very rightly pointed out, Siddesh, there is not a single system in the body which is not touched or affected by COVID. So you talk of neurological manifestations. Parkinsonism may get precipitated, accentuated, or prematurely brought in. Alzheimer's can become worse. You may need more medicines or newly set in. Type 2 diabetes can happen because the virus directly affects the pancreatic cells which produce the insulin. So those who never had a problem of sugar may now become newly diabetics. Those who were managed with oral hypoglycemic agents may need insulin. And those who were on insulin may need to step up the dosages of insulin. The worst of the lot are the lungs. And some of them become asthmatic. Some of them develop air trapped inside the lungs, what is called as bullae. And the worst of the lot develop interstitial pulmonary fibrosis, a very deadly disease. It affects even the bones. It affects your vessels. It leads to thromboembolic episodes, and therefore you hear at times of sudden deaths, cardiac arrest, or sudden strokes and hemiplegias. It has even driven some people impotent and erectile dysfunctions, and it has even changed the mindset of people. The memories have faded and the personalities have changed. So there is a need to set up post-COVID syndrome monitoring OPDs, and that has been done in most of the hospitals of the state. Now here I make an appeal to all you young people, to the media, to drive this message home to COVID affected people, that when we tell you to come back to hospital for 2.5 or 3 months later for an assessment, or use a mobile telephony app and send you a questionnaire, please reply to us. Please come back, because this is the best way to diagnose the post-COVID syndrome and then treat accordingly.
Yeah. Just kind of like towards the end, bringing it back to the task force. You mentioned the need for Indian health services, but with respect to task force, do you think maybe it's also time that states, or even at more local levels, districts, we need to have such task forces just as good contingency plan for maybe infectious diseases or outbreaks, but maybe also for like general non-communicable diseases, where the job of the task force is to actually get involved in health monitoring of the population.
Siddesh, I respectfully would differ you here. Just now there are district level task force in existence, and there is a coordination amongst us and every district place. A task force, basically this terminology comes from services, from military establishments. And as you know, it has a defined task. And that task has to be done in a specific period, in a specific duration. You have to go ahead and attack, like a surgical strike that our forces did, Air Force did. What we need to convert this is into something like a planning commission that we have in the center. We should have a planning commission at the level of the state, and they should not relegate themselves into the ivory towers of Mantralaya or Sachivalaya, but they should be working barefoot in the community. And that's the real thing that is required when you know the pulse of the society, of the community at the back of your palm. And then you can set up policies. So collecting data, having a direct connect with the populace, amalgamating and then analyzing the data that we have got, using research tools with which all of you are familiar with, deciding policies, converting that into strategies and action plans which have a time limit to execute. This is what is now required after COVID.
Yeah, thank you, sir. Yeah, thank you for being with us today. And this was definitely one of the most educational hours I have ever been through. So yeah, thank you everyone for joining us. We'll make the recording available in parts to all of you, and yeah, I hope everyone's safe. I hope that we focus on the big takeaways from here. And yeah, I wish good luck to everyone. Thank you so much.
Thank you. Thanks. Thank you.